Tachycardia means a fast heart rate, but not every tachycardia is dangerous. It may be a normal response to pain, fever, dehydration, blood loss, or anxiety. It may also be an abnormal heart rhythm that reduces cardiac output and causes shock, chest pain, pulmonary edema, loss of consciousness, or cardiac arrest. In this video, we will follow the adult tachyarrhythmia algorithm for a patient who still has a pulse. We will begin with the ABCDE assessment and decide whether the patient is stable or unstable. Unstable patients usually require synchronized electrical cardioversion. Stable rhythms are classified as narrow or broad complex and as regular or irregular. We will cover vagal manoeuvres, adenosine, atrial fibrillation, atrial flutter, ventricular tachycardia, pre-excited atrial fibrillation, and torsades de pointes. We will also review important drug doses, contraindications, and what to do if the patient deteriorates or loses their pulse. This video is intended for trained healthcare professionals. Always follow current local resuscitation guidelines, medication safety procedures, defibrillator instructions, and seek expert support when needed. What is tachycardia? Tachycardia means a heart rate above 100 beats per minute in an adult. However, the heart rate alone does not tell us the rhythm, the cause, or how dangerous it is. A mildly increased rate may be a normal response to pain, fever, blood loss, dehydration, or anxiety. In peri-arrest patients, hemodynamic problems are more likely when the ventricular rate is around 150 beats per minute or higher, although some patients may deteriorate at a lower rate. The important questions are, is this normal sinus tachycardia or an abnormal rhythm? Is the patient showing life-threatening features? Is the QRS complex narrow or broad? Is the rhythm regular or irregular? The tachyarrhythmia algorithm is used for abnormal rhythms. It should not be used to slow every patient with a fast heart rate. Sinus tachycardia starts in the sinus node. It usually has a normal P wave before each QRS complex, and the heart rate changes gradually with the patient's condition. Common causes include pain, anxiety, fever, infection, blood loss, dehydration, anemia, hypoxia, pulmonary embolism, heart failure, myocardial ischemia, thyroid disease, stimulants, and medication withdrawal. Treatment is directed at the cause, control bleeding, restore fluids when appropriate, treat hypoxia and infection, relieve pain, and correct significant anemia or electrolyte abnormalities. Do not treat compensatory sinus tachycardia with antiarrhythmic drugs or synchronized cardioversion. Slowing the heart rate may reduce cardiac output and delay treatment of the real problem. When the diagnosis is uncertain, obtain a 12-lead ECG and seek expert help while continuing immediate supportive treatment. For any patient with persistent tachyarrhythmia and a pulse, call for help and begin an ABCDE assessment. Check and protect the airway. Assess breathing, oxygen saturation, and ventilation. Give oxygen if the patient is hypoxemic, usually when oxygen saturation is below 94%. Assess circulation. Confirm a pulse, check blood pressure and perfusion, and look for signs of pulmonary edema or heart failure. Attach continuous ECG, blood pressure, and oxygen saturation monitoring. Obtain intravenous access and record a 12-lead ECG as early as possible. However, do not delay urgent cardioversion in an unstable patient. Save rhythm strips before and after treatment when possible. Assess consciousness, confusion, syncope, seizures, neurological signs, and blood glucose. Look for clues such as bleeding, infection, trauma, medications, or heart failure. At the same time, identify and treat reversible causes. Assessment and rhythm treatment should happen in parallel. Next, decide whether the tachyarrhythmia is making the patient unstable. Life-threatening features include shock with severe hypertension and poor organ perfusion, syncope, confusion, or reduced consciousness caused by poor cerebral blood flow, myocardial ischemia, shown by ischemic chest pain or new ECG changes, severe heart failure, especially pulmonary edema with marked breathing difficulty, tachyarrhythmia occurring immediately after return of spontaneous circulation. Always consider whether the abnormal rhythm is causing or worsening these features. If any life-threatening feature is present, treat the patient as unstable. Do not delay urgent treatment while trying to identify the exact rhythm. For unstable tachyarrhythmia with a pulse, give immediate synchronized electrical cardioversion, Synchronization allows the defibrillator to deliver the shock with the R wave. This reduces the risk of triggering ventricular fibrillation. Attach the pads, select synchronized mode, and confirm that a marker appears over each R wave. Choose the correct energy for the rhythm in a local protocol, make sure everyone is clear, and deliver the shock. After each shock, reassess the patient and rhythm. Confirm synchronization again before every further shock, because some defibrillators switch it off automatically. If the patient is conscious, provide sedation or anesthesia when it is safe and practical. However, sedation must not delay cardioversion in a critically unstable patient. Up to 3 synchronized shocks may be attempted while continuing the ABCDE assessment and treating reversible causes. Cardioversion energy depends on the rhythm, defibrillator, and local protocol. For atrial fibrillation, current Resuscitation Council UK guidance allows the maximum defibrillator output as the first synchronized shock. For atrial flutter or regular supraventricular tachycardia, start with 70 to 120 joules. For monomorphic ventricular tachycardia with a pulse, start with 120 to 150 joules. Increase the energy if the first shock fails. If 3 shocks are unsuccessful and the patient remains unstable, give an antiarrhythmic according to local protocol. Options include procainamide 10 to 15 mg per kilogram intravenously up to 1 gram over 20 minutes, or amiodarone 300 mg intravenously over 10 to 20 minutes. Then repeat synchronized cardioversion. Monitor the ECG and blood pressure closely because both medicines can cause hypertension and conduction abnormalities. If synchronization is impossible and the patient is critically unstable, an unsynchronized shock may be required. Unstable polymorphic ventricular tachycardia should be treated with an unsynchronized high-energy shock. If the patient has no life-threatening features, the tachyarrhythmia is currently stable, continue close monitoring and be ready to perform cardioversion if the patient deteriorates. Next, classify the rhythm using 2 questions. First, is the QRS narrow or broad? A narrow QRS is less than 120 milliseconds. A broad QRS is 120 milliseconds or wider. Second, is the rhythm regular or irregular? A regular rhythm has nearly equal R to R intervals. An irregular rhythm has changing intervals. Atrial fibrillation is typically irregularly irregular. This gives 4 groups: narrow and regular, narrow and irregular, broad and regular, broad and irregular. This classification guides treatment. Always review the 12-lead ECG, compare it with previous recordings when available, seek expert help, and continue reassessing the patient. A stable, regular, narrow complex tachycardia is often a supraventricular tachycardia caused by a re-entry circuit. The rhythm usually starts and stops suddenly. It is fast and regular, and the P waves may be hidden within or just after the QRS complexes. If the patient is stable, begin with vagal manoeuvres. If these fail, give adenosine when appropriate, and when there are no signs of pre-excitation, record the ECG continuously during treatment. If adenosine stops the tachycardia, this supports an AV node-dependent re-entry rhythm. If it only causes brief AV block, it may reveal atrial flutter or another atrial tachycardia. Vagal maneuvers slow conduction through the AV node and may stop an AV node-dependent supraventricular tachycardia. The modified Valsalva maneuver is usually preferred. While monitored, the patient performs a forceful strain. They are then laid flat and the legs are raised according to the local protocol. Carotid sinus massage should only be performed by a trained clinician after checking for contraindications such as carotid artery disease, a carotid bruit, or recent stroke or transient ischemic attack. Do not delay cardioversion to attempt vagal maneuvers in an unstable patient. If vagal maneuvers fail in a stable, regular, narrow complex tachycardia, proceed to monitored adenosine. Adenosine briefly blocks conduction through the AV node. This can stop an AV node-dependent supraventricular tachycardia. Give it through a secure, preferably proximal, intravenous cannula with continuous ECG monitoring and resuscitation equipment available. It must be given as a rapid bolus, followed immediately by a rapid saline flush. In the current Resuscitation Council UK algorithm, give 6 mg first. If the tachycardia continues, give 12 mg, followed by 18 mg if needed. Always follow one local protocol because dosing differs between guidelines. Warn the patient that they may briefly experience flushing, chest tightness, breathlessness, or feeling of impending doom. These effects usually last only a few seconds. Do not give adenosine if there is evidence of pre-excitation. Use caution in severe asthma, transplanted hearts, and with medicines that increase its effect. Adenosine is mainly used for regular tachycardias. In a broad complex rhythm, consider it only when the rhythm is regular and monomorphic, and supraventricular tachycardia with aberrancy is strongly suspected. If vagal manoeuvres and adenosine do not stop a stable, regular, narrow complex tachycardia, reconsider the diagnosis and seek expert help. Current Resuscitation Council UK guidance allows verapamil or a beta blocker as the next treatment. If the rhythm continues, synchronised cardioversion may be required. Verapamil and beta blockers slow conduction through the AV node, but both can cause hypertension and bradycardia. Avoid verapamil in severe left ventricular dysfunction and never use it for an undiagnosed broad complex tachycardia. Use beta blockers cautiously in hypertension, acute heart failure, conduction disease, or bronchospasm. Avoid combining multiple intravenous AV-nodal blocking drugs without expert supervision. If the patient becomes unstable at any time, perform immediate synchronized cardioversion. An irregular narrow complex tachycardia is most commonly atrial fibrillation. Other causes include atrial flutter with variable conduction, multifocal atrial tachycardia, and frequent atrial ectopic beats. Atrial fibrillation has no consistent P waves and is irregularly irregular. Atrial flutter may show sawtooth flutter waves and can be regular or irregular depending on AV conduction. In a stable patient, treat reversible causes. Control the ventricular rate when appropriate, consider whether rhythm control is needed, and assess stroke risk and the need for anticoagulation. Adenosine does not treat or terminate atrial fibrillation. It may briefly reveal underlying atrial activity, but treatment must then follow the rhythm identified. In stable atrial fibrillation, treatment may focus on controlling the ventricular rate. The choice of medicine depends on the patient's left ventricular function and other clinical factors. If the ejection fraction is above 40%, options may include a beta blocker, verapamil, diltiazem, or digoxin. If the ejection fraction is below 40%, consider a beta blocker or digoxin. Avoid verapamil and diltiazem because they may worsen systolic heart failure. Digoxin is most effective at rest and may work more slowly during acute illness or high sympathetic activity. Use it cautiously in kidney impairment, older patients, and when interacting medicines are present. Do not use rate control medication instead of cardioversion when atrial fibrillation is causing life-threatening instability. Never give AV-nodal blocking medicines in pre-excited atrial fibrillation because they may increase conduction through the accessory pathway and trigger ventricular fibrillation. Atrial fibrillation may be treated with electrical cardioversion, antiarrhythmic medication, or later catheter ablation. The choice depends on symptoms, how long the rhythm has been present, structural heart disease, and specialist assessment. If atrial fibrillation is causing hemodynamic instability, perform immediate synchronized cardioversion. Do not delay emergency treatment for a prolonged anticoagulation assessment. Begin anticoagulation as soon as it is safe. In a stable patient, cardioversion may cause thromboembolism when atrial fibrillation has lasted more than 24 hours or the onset is uncertain. Elective cardioversion usually requires at least 3 weeks of effective anticoagulation or imaging to exclude an atrial thrombus. Anticoagulation is generally continued for at least 4 weeks after cardioversion. Longer treatment depends on the patient's ongoing stroke risk, even if sinus rhythm is restored. The choice and timing of anticoagulation depend on stroke risk, bleeding risk, kidney function, valve disease, drug interactions, and local guidance. Remember that rate control, rhythm control, and stroke prevention are separate decisions. Controlling the heart rate does not remove the need to assess anticoagulation. A broad complex tachycardia has a QRS duration of 120 milliseconds or more. A regular, broad complex rhythm may be ventricular tachycardia or a supraventricular tachycardia with abnormal ventricular conduction. Unless there is clear evidence of a known supraventricular rhythm with the same QRS pattern, treat it as ventricular tachycardia. Ventricular tachycardia is more likely in patients with previous myocardial infarction, cardiomyopathy, heart failure, structural heart disease, or previous ventricular arrhythmias. Do not give verapamil or diltiazem to an undiagnosed broad complex tachycardia. If the rhythm is ventricular tachycardia, these medicines may cause severe hypertension or cardiovascular collapse. If the patient has any life-threatening features, perform immediate synchronized cardioversion. Even a stable patient with monomorphic ventricular tachycardia requires urgent treatment and close monitoring because deterioration can occur suddenly. A stable, regular, broad complex tachycardia should usually be treated as ventricular tachycardia. Current Resuscitation Council UK guidance generally recommends synchronized cardioversion, especially when structural heart disease is present or the diagnosis is uncertain. In a stable patient, adenosine may be considered only when the rhythm is regular and monomorphic, and supraventricular tachycardia with aberrancy is strongly suspected. If it does not stop the rhythm, treat it as ventricular tachycardia. When cardioversion or sedation carries significant risk, drug treatment may be considered. Give procainamide 10 to 15 mg per kilogram intravenously over 20 minutes according to the local protocol. If procainamide is unavailable or contraindicated, give amiodarone 300 mg intravenously over 10 to 60 minutes, followed by 900 mg over 24 hours. Monitor the ECG and blood pressure closely. Avoid procainamide in marked QT prolongation or severe heart failure. Do not use amiodarone for torsades de pointes with prolonged QT. If treatment fails or the patient deteriorates, perform synchronized cardioversion. An irregular, broad complex tachycardia is a high-risk rhythm. Seek expert help immediately. Possible causes include atrial fibrillation with bundle branch block, pre-excited atrial fibrillation, and polymorphic ventricular tachycardia. Atrial fibrillation with ordinary bundle branch block may follow the atrial fibrillation pathway after expert confirmation. However, pre-excited atrial fibrillation and polymorphic ventricular tachycardia require different treatment. Do not give adenosine to an irregular, broad complex rhythm. Avoid beta blockers, verapamil, diltiazem, and digoxin if pre-excitation is possible. If the patient is unstable, give electrical treatment. Polymorphic ventricular tachycardia cannot be reliably synchronized, so use an unsynchronized high-energy shock. If the patient loses their pulse, begin the cardiac arrest algorithm immediately. Pre-excited atrial fibrillation occurs when an accessory pathway allows impulses to bypass the AV node. The ECG may show very fast, irregular, broad complex rhythm with changing QRS shapes. This is dangerous because it can deteriorate into ventricular fibrillation. Do not give AV-nodal blocking drugs, including adenosine, beta blockers, verapamil, diltiazem, or digoxin. These medicines may increase conduction through the accessory pathway. In a stable patient, Current Resuscitation Council UK guidance recommends procainamide or electrical cardioversion. If the patient has any life-threatening features, perform immediate electrical cardioversion and seek urgent specialist help. Do not routinely give amiodarone when pre-excited atrial fibrillation is possible. Polymorphic ventricular tachycardia has QRS complexes that continuously change in shape and direction. Torsades de pointe is a type of polymorphic ventricular tachycardia associated with a prolonged QT interval. Common causes include low potassium, low magnesium, bradycardia, heart disease, and QT prolonging medicines. Review the medication list and correct electrolyte abnormalities. For torsades with a pulse and prolonged QT, give 8 millimoles of intravenous magnesium over 10 minutes, according to the local medication protocol. In selected cases, temporary pacing or isoprenaline may be used to increase the heart rate under expert guidance. Avoid amiodarone because it may further prolong the QT interval. If the patient is unstable, give an unsynchronized high-energy shock. If the patient has no pulse, begin CPR and follow the shockable cardiac arrest algorithm. Treating the rhythm is only part of the management. Continue searching for and correcting the underlying cause. Common triggers include hypoxia, blood loss, dehydration, fever, sepsis, pain, anemia, acid-base disturbance, and abnormal potassium, magnesium, or calcium levels. Also consider acute coronary syndrome, heart failure, myocarditis, pulmonary embolism, thyroid disease, medicines, stimulants, and drug withdrawal. Investigations may include blood glucose, blood gas, lactate, full blood count, electrolytes, kidney function, magnesium, cardiac biomarkers, and toxicology testing, depending on the clinical situation. Record the 12-lead ECG before and after treatment when possible. Previous ECGs, echocardiography, and specialist review may help identify the rhythm and underlying heart disease. Correct the cause while treating the tachyarrhythmia. Otherwise, the abnormal rhythm may return even after successful cardioversion or medication. A stable patient can deteriorate at any time. Continue monitoring the ECG, blood pressure, oxygen saturation, consciousness, breathing, chest symptoms, and circulation. If the patient develops shock, severe hypotension, syncope, myocardial ischemia, pulmonary edema, or another life-threatening feature, move immediately to electrical treatment. Most unstable tachyarrhythmias with a pulse require synchronized cardioversion. However, polymorphic ventricular tachycardia requires an unsynchronized, high-energy shock. If the patient becomes unresponsive and is not breathing normally, check for a central pulse for no more than 10 seconds. If there is no definite pulse, begin high-quality CPR, call the cardiac arrest team, and follow the adult cardiac arrest algorithm. Ventricular fibrillation and pulseless ventricular tachycardia are treated with unsynchronized defibrillation, not synchronized cardioversion. After return of spontaneous circulation, repeat the ABCDE assessment, treat the underlying cause, and manage any significant tachyarrhythmia urgently. Successful conversion is not the end of treatment. Repeat the ABCDE assessment, check the vital signs, and obtain a 12-lead ECG in the new rhythm. Look for myocardial ischemia, conduction abnormalities, pre-excitation, QT prolongation, electrolyte disturbance, or structural heart disease. Repeat blood tests when needed. Document the original rhythm, symptoms, treatments, medication doses, shock energies, sedation, response, and any complications. Save rhythm strips whenever possible. Arrange appropriate monitoring and specialist review. Urgent assessment is especially important after ventricular tachycardia, pre-excited atrial fibrillation, recurrent syncope, significant QT prolongation, structural heart disease, or a peri-arrest event. For atrial fibrillation, make a clear plan for rate or rhythm control, anticoagulation, and follow-up. For recurrent supraventricular tachycardia, consider electrophysiology assessment or catheter ablation. Before transfer or discharge, treat the underlying cause, review the patient's medicines, and explain what to do if symptoms return. Let us finish with the complete adult tachyarrhythmia algorithm for a patient with a pulse. Begin with an ABCDE assessment. Attach ECG, blood pressure, and oxygen saturation monitoring. Obtain intravenous access. Record a 12-lead ECG when possible, and treat reversible causes. Give oxygen only if the patient is hypoxemic, and call for expert help early. Next, look for life-threatening features. Shock, severe or ongoing hypertension with syncope, myocardial ischemia, severe heart failure with pulmonary edema, or tachyarrhythmia immediately after return of spontaneous circulation. If any are present, the patient is unstable. Give immediate synchronized cardioversion with sedation or anesthesia when feasible. Up to 3 attempts may be required. If unsuccessful, give procainamide or amiodarone according to the local protocol. Then repeat cardioversion. If the patient is stable, classify the rhythm. For a narrow, regular rhythm, begin with vagal manoeuvres. If these fail and there is no pre-excitation, give adenosine, 6 mg, then 12, then 18. Consider verapamil or a beta blocker, followed by cardioversion if needed. For a narrow, irregular rhythm, could be atrial fibrillation. If ejection fraction is more than 40%, consider beta blockers or verapamil or diltiazem or digoxin. If ejection fraction is less than 40%, consider beta blocker or digoxin, and also give anticoagulation. For broad, regular rhythm, treat as ventricular tachycardia. Synchronized cardioversion is preferred. Procainamide or amiodarone may be used when anesthesia is considered too risky. A broad, irregular rhythm is high risk. Pre-excited atrial fibrillation requires procainamide or cardioversion. For polymorphic ventricular tachycardia with a prolonged QT interval, give magnesium and avoid amiodarone. Continue reassessing the patient. If polymorphic ventricular tachycardia becomes unstable, give an unsynchronized shock. If the pulse is lost, begin CPR and follow the cardiac arrest algorithm. Always treat the patient, the rhythm, and the underlying cause together. Thank you for watching.